Hello and welcome. My name is Eric Cucci. I'm a physician assistant in critical care, the director of EICU operations, and the critical care informatics officer here at UMass Memorial Medical Center. The video you're about to watch is brought to you by the UMass Memorial Medical Center Critical Care Committee and the Division of Gastroenterology. We will delve into the procedure for placement of a gastroesophageal balloon tamponade, or GEBT, on specifically the placement of a Minnesota tube.
When dealing with GEBT here at UMass, one of the first things you should do is to familiarize yourself with the clinical standard operating procedure for gastroesophageal balloon tamponade, which is located on the hub.
The next thing you need to understand is what the alternative therapies to GEBT. Possible alternatives and therapeutics could be band ligation, sclerotherapy, glue injection for gastric varies, or esophageal stenting are some of the first-line therapies for variceal bleed. All these, of course, are performed endoscopically by gastroenterologists. Vasoactive pharmacologic therapy, such as octreotide or terlipressin, can help diminish portal vein pressure and help control the hemorrhage. Another alternative is transjugular intrahepatic portosystemic shunt, or TIPS, which is oftentimes used as a bridge to liver transplant. Indications for GEBT include shock index greater than 1.3, significant pressure requirements despite blood products' large volume resuscitation, and worsening hemodynamic instability. Esophageal variceal hemorrhage, in whom neither sclerotherapy nor band ligation is technically possible, readily available, or has already failed. Absolute contraindications are recent esophageal surgery, history of gastric bypass and/or esophageal strictures. Relative contraindications include cardiac arrhythmia, respiratory failure, although most patients will already be intubated or should be intubated for airway protection, and hiatal hernia. Adverse events include tube migration, death, acute laryngeal obstruction, tracheal rupture, perforation of the esophagus, aspiration pneumonia, mucosal ulceration at the GE junction, secondary to prolonged traction, inability to deflate the balloon, necrosis of the nostrils or oral labia, and nasopharyngeal bleeding. The key to successful placement of a Minnesota tube is preparation and setup. If the patient is relatively stable, you should attempt to obtain informed consent from either the patient or from the medical decision-maker. Unfortunately, these patients may be so unstable that informed consent is not possible. If the patient hasn't yet been intubated, then the patient should have their airway secured with an endotracheal tube. The patient's hemodynamics should be addressed, and ongoing resuscitation should not be paused or delayed while deciding, preparing, and placing a GEBT. The GEBT kits should include a Minnesota tube manometer scissors 2, rubber shod clamps, copious water-based lubricant, marking pen 2, 3-way stopcocks, 2 IV claves, lure locks, 60 ml, lure lock, syringe, 60 ml cath, type syringe tape, self-inflating bulb, normal saline flushes. 1 liter bag of IV saline Curlex. Although not included in the kit, reliable suction should be available. Before we go further, let's discuss the anatomy of the Minnesota tube. The Minnesota tube has a gastric balloon, esophageal balloon, 4 ports that we will review in a moment, and 10 centimeter tick marks to help guide your depth. Here you can see where the rubber shod clamps are placed to prevent loss of pressure from the balloons. The Minnesota tube has 4 lumens, 1 for the gastric balloon, 1 for the esophageal balloons, 1 for the gastric aspiration port, and 1 for the esophageal aspiration port. There are 2 additional pressure monitoring ports for the gastric and esophageal balloon ports. Each port has white plugs that work to plug but not seal the ports. Here we see 3-way stopcocks with lure locks placed within the balloon ports. Note that the white plugs remain within the additional pressure monitoring ports. When injecting air into the balloons, you would use the 60 ml lure lock syringe through the 3-way stopcock. Please make sure that the off position is as seen here in this picture. Do not use the 3-way stopcock to prevent air loss from the balloons. You will use the rubber shod clamps for this. For simplicity, you can use the 60 ml catheter tip syringe directly into the port without the three-way stopcock, but the stopcock will be needed for pressure testing. The 60 ml catheter tip syringe is used to aspirate or inject air into the aspiration ports. To connect the manometer to the lure lock, press firmly, no twist needed, and you should see the needle move immediately with a pressure reading in centimeters of water.
Now that you know the indications, adverse events, contraindications, the anatomy of the Minnesota tube, and have all your equipment, it's time to start preparing for the procedure. First, you must test the gastric balloon by inflating 80 milliliters of air to ensure gastric balloon is intact. If the balloon is intact, then the manometer should be used to test the pressure, which should be around 100 centimeters of water. Record and remember the pressure.
Then inflate the esophageal balloon to ensure it's intact. No need to check a pressure on the esophageal balloon. You can see here that you should be using the rubber shod clamps to seal the tube between injections of air. Once you have ensured that the balloons are intact and the pressure of the gastric balloon, you should fully deflate both balloons. The next step is to liberally lubricate the entire Minnesota tube with water-soluble lubricant. Now it's time for the placement of the Minnesota tube. The first thing you want to do is insert the tube via the mouth to 30 to 35 centimeters. You can use the nasal passages for insertion, however. In an intubated patient, oral insertion is preferred. Once at 30 to 35 centimeters, you'll use the self-inflating bulb placed into the gastric aspiration port to help determine if the tube is in the esophagus or within the trachea. Here, you can see that the self-inflating bulb after 5 seconds has not reinflated, suggesting that it is in the esophagus. In the insert, you can see that the self-inflating bulb reinflates rapidly, suggesting that the tube is in the trachea. After the self-inflating bulb has confirmed that the tube is within the esophagus, you should advance the Minnesota tube to approximately 45 to 60 centimeters at the teeth. If there is difficulty placing the tube, sometimes you may need laryngoscope and/or a bougie to help advance the tube. A bougie may be used as an adjunct for assistance with placement of the Minnesota tube. Place the straight end of the bougie, not the coude tip, into the most proximal of the 3 gastric aspiration ports. Insert approximately 0.5 centimeters. The fully assembled apparatus may be inserted as an OG by pushing the bougie intentionally down the esophagus. Once fully inserted and placement confirmed, in one swift movement remove the bougie. The inflated Minnesota tube will remain in place. Once at depth, you should auscultate over the epigastrium while injecting air through the gastric aspiration port, listening for a gastric bubble. At this point, you will inject 80 milliliters of air into the gastric balloon and then clamp the gastric balloon port with the rubber shod clamps. You should not meet resistance if in the correct position.
After inserting the 80 milliliters of air into the gastric balloon, you will want to test the pressure. The pressure should equal the pressure that you noted when you did the test pressure of the gastric balloon during the preparation stage. At the very least, the pressure should be within 20 centimeters of water of the test pressure. If greater than 20 centimeters of water, then it suggests that the gastric balloon is within the esophagus and will need to be repositioned.
Before proceeding, we will need to get a chest X-ray to ensure the placement of the Minnesota tube. The gastric balloon and the tip of the catheter must both be below the diaphragm as seen here in this chest X-ray. Once the placement of the Minnesota tube is confirmed by chest X-ray, you should slowly inflate the volume of the gastric balloon with 450 to 500 milliliters of air. Using a 60 milliliter syringe, inject air into the gastric balloon. In between each injection of air, ensure that the rubber shot clamp is sealing the gastric balloon port. At this point, you should check to see if hemostasis has been achieved. If bleeding continues, then the tube should be pulled up until resistance is felt. Mark the tube at the level of the teeth so that the tube can be monitored for migration. Next, you will tie one end of the roll of Curlex to a 1-liter bag of saline. The other end of the Curlex roll should be tied to the Minnesota tube below the ports, and then place the saline bag over an IV pole to create traction. The gastric aspiration port should be connected to low-wall intermittent suction. At this point, you should check again to see if hemostasis has been achieved. If the hemorrhage is now under control, then the procedure is completed, and documentation should be done within epoch.
If bleeding continues, then the esophageal balloon should be inflated. You will need to inflate the esophageal balloon up to 34 centimeters of water and check for hemostasis. If bleeding continues, then you can continue to increase the pressure within the esophageal balloon incrementally up to 61 centimeters of water. The lowest esophageal pressure that is required to maintain hemostasis is the pressure that should be used.
If the hemorrhage is now under control, then the procedure is completed, and documentation should be done within epoch. The esophageal balloon inflation must always be done under strict pressure monitoring, as the risk of necrosis and/or perforation is high. The esophageal balloon should not remain inflated for longer than 12 to 24 hours. Care and maintenance.
Maintain tamponade therapy until hemostasis has been obtained, up to a maximum of 24 hours for esophageal balloon. Assess and monitor for changes in position of the permanent marker to ensure the tamponade tube has not slipped out of place. Esophageal pressure should be between 34 and 61 centimeters of water. Complete deflation of the esophageal balloon, at least for 5 minutes every 6 hours. Keep scissors and a 60 milliliter Lure-Lock syringe at the bedside to immediately deflate the balloon if indicated. This may be needed for emergency complications such as esophageal rupture. Obtain a chest X-ray and KUB every 24 hours or as needed if there is any indication of displacement. Monitor gastric output. If the patient is to be placed on an aircraft, replace the esophageal balloon air with sterile water. Maintain pressures between 34 and 61 centimeters of water. The tube should be left in place until a more definitive therapy, such as TIPS, can be done. If there is no evidence of bleeding, the gastric balloon should be deflated. The tube should remain in place 24 hours. If bleeding reoccurs, the balloons can be reinflated, following the procedures shown here.
Removal. Untie the Curlex from the tube and remove the clamps. Remove the air from both the gastric and esophageal balloons. Gently remove the tube. If you feel resistance, then try to remove more air from the balloons and try again. Thank you for reviewing the placement of a Minnesota tube at UMass Memorial Medical Center.